Sorry for the delay. Hi, my name is Charles Nimo, and I'm a third-year PhD student in computer science at Georgia Tech. And the title of my talk is Africa Health Check, Probing Cultural Bias in Medical LLMs. And I'm honored to be presenting our research at ACM Emo this year, and also grateful for the chance to share our work with such an inspiring community. I also want to give a big thank you to my wonderful co-authors. So let me start with a quick description. A person in Nigeria asked about malaria treatment. The non-adaptive response, ACT is a first-line treatment and consult a doctor, is clinically right, but it ignores local realities. There's no acknowledgement of common local practices, no guidance about how to act given what's actually available, and no bridge to local care. In practice, that kind of answer can feel distant or even unusable. By contrast, the culturally adapted answer still reaffirms ACT as a first-line treatment. So we're not changing the medicine, but it also recognizes local practice. And it points the person to local clinical care. Same core fact, but very different usefulness, trust, and likely adherence. This mismatch isn't a one-off. It reflects the conditions many people bring to these systems. So before we evaluate models or methods, it helps to name the real-world context users are operating in, which raises the next question: what context are people actually bringing to medical LLMs? So two realities shape how people use medical LLMs. First, access is uneven. Language, supply, affordability, and care pathway constraints all affect whether advice is actionable. Even the most accurate guidance can fall flat if it doesn't translate into next steps where someone lives. Second, care is plural. In many places, especially across Africa, traditional remedies and allopathic medicine coexist. So when someone asks about malaria, they're weighing familiar local practices alongside clinical recommendations. And that's the landscape our work is concerned with, not just what's medically correct, but what's usable and trustworthy in context. So with that motivation in place, we can look at how models actually behave in these settings and when added context really helps versus when it risks amplifying bias. So on the last slide, we named two realities: access is uneven and care is plural. To study model behavior in that landscape, we need a workable frame of culture and a clear sense of what we're trying to learn. So how do we frame culture in the study? We use country-level context as a practical proxy for culture. It's not perfect because there's real diversity within countries, but since treatment guidelines, formularies, and norms are usually organized at that level, it's usually a good starting point. So within that frame, we focus on a space where cultural practice is most visible: traditional African herbal remedies versus allopathic care, which is the conventional Western-style medicine most clinical systems are built around. And that contrast mirrors what many users actually weigh when they turn to medical models for guidance. So what we're trying to learn: first, do models lean toward one family of options? And secondly, we quantify outcome bias, asking whether models default toward allopathic or traditional remedies when both are plausible. Second, we also want to understand why do outputs shift. We measure how prompt phrasing influences those biases to separate the model's built-in tendency from what the prompt is pushing it to do. So this gives us a clearer, cleaner way to discuss behavior than accuracy alone. So here's what we contribute. So now that we've set up the framing and goals, here's what we actually add to study cultural appropriateness in a systematic way. First, we start with a reference data set. We curated over 130 traditional herbal remedies from about 10 African countries, documenting the plant, the country or region where it's used, and what condition it's meant to treat. These came from ethnobotanical surveys and peer-reviewed studies. That gives us grounded country-specific anchors for building realistic questions and context. Second, we use two complementary metrics, so we're not just scoring right or wrong answers. The first metric is CBS, or cultural bias score, which captures the model's outcome preference, which is how often it leans towards herbal versus allopathic care when both are plausible. And then second metric is CBA, which is cultural bias attribution, and it measures the why. It measures how much that lean changes because of the prompt itself or the influence of wording and context. And then third, we look at model behavior on the two evaluation setups. And the first evaluation setup is the multiple choice task where we vary the context, no context, correct, full context, and misleading context to check how models perform. And we see does adding the right local information help them choose the culturally aligned answer. And can misleading cues push them in the wrong direction? And the second task is the paired fill in the blank task, where we get two completions, one herbal, one allopathic, and test them on the zero shot, few shot, and instruction tune prompts. And here we compute both CBS and CBA to tease apart what comes from model priors versus what's shaped by the prompt. So together, the dataset, the dual metrics, and the two tasks let us see how context and phrasing shifts language model recommendations. So how do we curate the dataset? So here's the dataset that grounds our evaluation. We target, again, African traditional herbal medicine because it's a live part of primary care for many people and gives us a concrete way to test cultural relevance. Our coverage spans across 10 countries, 100 plus remedies, and 130 plus country remedy pairs. And for each entry, we keep the country, the common and clinical names, indication, and the plant parts used. And so the goal is a high confidence reference that lets us ask models questions whether both allopathic and traditional options are clinically plausible so we can observe whether models align to the local context. And then we do quality control where we invested some time and we applied WHO aligned safety efficacy criteria and the clinical equivalence filter where we keep a traditional remedy only if peer-reviewed sources suggest comparable outcomes and acceptable safety relative to an allopathic counterpart for the same indication. So then we then validated botanical names programmatically, clean duplicates, and fixed missing fields. And again, this results in a high confidence subset that is appropriate for probing model behavior rather than debating plant taxonomy. So with data in place, we designed two complementary tasks. Again, the first is the multiple choice setup with aligned answers and distractors where we vary context to test robustness. And the second is a pair completion setup where we present traditional versus allopathic so we can measure what the model prefers and why that preference shifts with prompts. So within the MCQ task, it mirrors real decisions, traditional options, one aligned, one distractor, and two allopathic options, one aligned, again, one distractor. And we run these three variants. With no context, we restrict cues to see baseline bias. With full context, we supply correct local detail. Um, and with misleading context, we introduce plausible but wrong cues to see if model chases surface level cues. So second task, the fill in blank, where we remove distractors and pits a vetted TM completion versus an allopathic one, so we can quantify preference and prompt influence precisely. So let's move on to the metrics. The first metric that we use in the second task, fill in the blank task, is CBS, cultural bias score. And it's a black box preference score for each prompt, where we compare the model's average log probability for the allopathic completion versus the traditional one. If allopathic treatment wins, then the item that contributes won, which is average over items. A higher CBS means more allopathic lean. This is what the model tends to choose and not a medical accuracy judgment. On the other hand, CBA is or culture bias attribution is a white box view using integrated gradients. And here we compute how much the prompt tokens contribute to each candidate score, integrating from a baseline prompt shift of cultural cues to the real prompt. So if attribution is higher for AM or allopathic medicine, this contributes to one, which averages again across all the items. And higher CBA means that prompts are not lean towards priors and are driving the allopathic lean. So together, CBS tells us what, and CBA tells us why. So here's a quick way to read this two-dimensional bias landscape mappings. The x-axis called CBA shows how much the prompt wording drives the model's response, and the y-axis CBS shows which way the model leans overall, toward allopathic or traditional care, and how strong that lean is. Now, if both CBS and CBA are low, the model is fairly neutral and not very prompt sensitive. Responses look appropriate, contextually sound, and consistent. That's a stable baseline. But if they seem uncertain or inconsistent, that usually signals ambiguity in the item, so it's better to refine the question or add clarifying context rather than keeping adjusting prompts. So when CBS is high and CBA is low, that means that there's a built-in lean that prompts don't really shift. If you want a different behavior, model data level changes will be more effective for prompt engineering. When CBS is lower, but CBA is high, the model is highly responsive. And when both CBS and CBA are high, that means that the model already leans one way and the prompt is reinforcing it. So that amplified bias usually needs a two-part fix, adjusting both the prompt and the underlying data or model. So the big picture is reading both axes together keeps us from overinterpreting one number. CBS tells us what the model tends to choose, and CBA tells us why, whether it's driving the model's priors or by the prompt itself. And that's what helps us decide whether to intervene with prompts or with data in model updates or both. So now that we covered the metrics and experimental setup, let's look at what we actually found. In the MCQ setup, multiple choice question setup, we add correct patient and cultural details, increases traditional medicine aligned accuracy across models, which is expected and desirable. However, we also observe a match increase in traditional medicine detractor selections. This pattern indicates feature level sensitivities to surface level cues rather than verifying the indication specific constraints that distinguish the correct traditional medicine option from a plausible but wrong one. Under the misleading context, some models show further gains in traditional medicine picks, but the improvement is spurious. Attribution is aligned to the misleading features, not to the clinical signal. So the apparent accuracy reflects pattern matching rather than grounded reasoning. So in this case, our bus response profile looks more like a higher TM accuracy under full context by using contextual details to select the right traditional medicine option, and with minimal change under misleading context, indicating resilience to spurious cues. And on the CBS and CBA plot, you'll notice the zero-shot prompt setting on the inherent bias zone, which is a strong allopathic lean with only modest prompt influence. When we move to few shot setups, things generally shift left and up, lower CBS, higher CBA, which tells us that the examples are helping to change behavior. And we can actually see the prompt starting to do the work. Now, once we get to instruction tuning, the patterns diverge. One model moves towards balance, showing a more neutral prompt effect, while another drifts into amplified bias, where prompts actually reinforce that allopathic lean. And this is exactly why interpreting both axes matter. CBS shows us, again, what the model tends to choose, and while CBA shows us why it's doing that. So what did we learn? Here's the main takeaway. So first, guidance that ignores local context is tough for people to use. And when we add the right patient and cultural details, the full context condition models do pick the correct traditional remedy more often, which is good. But we also see more wrong traditional picks at the same time. And that tells us some models are reacting to server signals instead of checking which specific herbal option matches the condition. And when we add misleading details, a few models seem to improve, but only because those hints point to the detractor, and so the bump isn't really a real performance. It's actually pattern matching. And so the practical lesson, we should pair contextualization with robustness checks. Our toolkit dataset task and the two metrics separates what the model tends to choose and from why it shifted. And reading the CBS and CBA map then tells us where to intervene and how do we tweak prompts and guardrails, or do we need model and data changes. So looking ahead, next, we want to grow breadth by adding more countries and regional variants. We want evaluations that match real use, so we'll add local languages and also when useful images. More importantly, we'll want to bring clinicians into the loop, not just to score answers, but to check agreement between the judgments and our CBS and CBA metrics. And when clinicians and metrics line, we know that we can have confidence in these metrics alone. And when they disagree, that kind of gives us a flag for cases for error analysis. Thank you so much. Please scan the QR code to check out the full paper. And I'm also happy to connect and continue conversation on culturally aware and reliable AI. Thank you for your attention.
Thank you. Do you have any questions?
Thanks for this talk. I think this was on your future work slide, but I'm very interested in how different languages are going to affect the quality of this information. And especially when people are switching sort of from asking Dr. Google to asking Dr. Chatbot, what difference in kind of the quality of medical advice are people going to get based on the languages they're asking? Do you have any ideas about what that's going to be like from your work so far? Thanks.
Yeah, I think we would kind of see similar behavior from what I examined in my study. I think what we see is that a lot of times that the models itself would generate responses that align with more of, say, like the allopathic treatments or the its patterns from its learned priors or training knowledge, or rather than contextualizing the responses towards the given culture or language or the person that it's responding to. And so I think you probably see a similar behavior across the different languages, but it would be something interesting to see itself. But that's just my hypothesis.
Thank you.